Hi viewers, today let's discuss about original widman flap. In the last video, I have given a brief introduction about the periodontal flaps, the classification, everything. For those who have not seen that video, please go and watch that and then you come to this video so that you'll understand this video better. Let's start. The original widman flap are the olden technique. Nowadays, we are not using this technique. Many other techniques are there for the pocket elimination and for the pocket reduction. So the main aim of this original widman flap is the pocket elimination because we are going to remove the complete pocket. Let's see how we do this. So the main features of this original widman flaps are the apical positioning of the flap. That means we are not going to place the flap back to the original position. We are going to shift that apically. And the other thing is that bone recontouring. That is, we are eliminating the angular defects so as to achieve proper pocket elimination. So these two are the main steps in this technique. So first let's start about how the procedure goes. The first is that we need to give the incision. You know, any techniques, any periodontal flap techniques, we have to give the incisions. So I have made a video about incisions and the type of incisions. For those who want to know more about incisions, you can watch that. In this, I am going to just give a little demo so that you can understand this better. So here we give the horizontal scalloped incision, which is internal bevel submarginal. That means in this original widman flap technique, we are going to give the incision like internal bevel submarginal horizontal scalloped incision. By see, this is little lengthy, so you may get confused. So I'll give this demo so that you can understand better. That means first we have to give the internal bevel incision. Internal bevel means we are going to move the end of this blade towards the root area from the external surface to the internal surface. This is known as the internal bevel incision. So we have to start from here. See, we need to give the incision here, internal bevel. That means from here we need to go to the root level. And this, then like this. So this is like a scalloped. That means we need to follow the contour. And this is horizontal, not vertical. So that is horizontal scalloped. Submarginal means this is the marginal area. We have to give little 0.5 to 1 mm distance. We need to give this much of distance, so that is known as submarginal. So everything is, I think you are clear with this. Internal bevel submarginal horizontal scalloped incision. So we have to give this kind of incision. See, and then we need to remove this part. See, in this model I cannot do nicely, that's why like this. So this is the internal bevel submarginal horizontal scalloped incision. So why we are doing this means to demarcate the diseased pocket elimination and inflamed connective tissue from the non-inflamed counterpart. So before removing this, so first incision is like this, internal bevel scalloped horizontal incision. After that, we need to give two sectional incision. That is the vertical releasing incision. That means it has to go like this, vertical to vertical releasing incision. Can you see? This is like vertical releasing incision. So we have given this, and then we need to reflect the flap. So you can reflect the flap, and then we can remove this portion. See, this tissue was there, no? This tissue we have to remove, and then we need to reflect the flap. See, now we have reflect the flap. So after the flap reflection, that means it is a full thickness flap. We have removed all the periosteum, everything. And then after this exposed at least 2 to 3 mm of the marginal alveolar bone. And this tissue is, and we have removed this tissue with the help of curettes. Actually, we have to use the curettes to remove the extra tissues. So I think you are clear with these two. That means here the flap reflected, and then this tissue got eliminated. And the next step is that, So now we have clear picture of underlying bone and the root surface. So now we got access to underlying root and also the bone. Bone means at least 2 to 3 mm of the marginal alveolar bone. And after this, it's very easy for to do the scaling and root planning. So now we can do the scaling and root planning. That means the thorough debridement of the root surfaces. So now we have done the scaling, and then we need to do the bone recontouring. That this is the thing I told you just before, that because the architecture of the bone is damaged due to disease activity, so we have to give some reshaping or recontouring. That also we have to do. And after this, so we have done everything. We have done the thorough debridement, everything. So the root area we have done the debridement, and the bone area we have given the contouring. So everything is finished. The next step is to place back the flap. So we need to place back the flap. So when we need to place back the flap, the flap margin should coincide with the level of the bone margin. It should not go like this. So the flap margin should coincide with the level of the bone margin. Suppose if this is the bone margin, so the flap has to place back here, not till here. Okay, so now the flaps are repositioned so that they rest on the alveolar bone. So this is the alveolar bone. So now the flaps rest on the alveolar bone. So no scope for pockets now. This is how the pocket elimination is achieved. So now no space between the flap margin and the bone margin. Now both are at the same level. So there is no scope for the pocket. This is how we do the pocket elimination by the original widman technique. And after that, we can do the interproximal suture. So this is the original widman technique. And then we have to understand the disadvantages and disadvantages of this technique. Advantages are definitely the pocket elimination, and healing would be via the primary intention, so patient has less pain and discomfort, and we can expect some increase in the width of the attached gingiva. The disadvantages are the sensitivity, because the root has exposed here more, so the patient can feel the sensitivity, and this technique cannot be done in the aesthetic zones, especially in the upper anterior area. We cannot do this because we have almost cut this much of portion, so this area will be exposed, so it would be unaesthetic. So this is all about original widman technique. Thank you.